There is a pill that over 50 million Americans take every single night before bed. It is sold in every pharmacy in this country. It is available without a prescription. Doctors recommend it routinely. And according to research published in JAMA Internal Medicine, long-term use of this medication is associated with a significantly increased risk of dementia. Most of the people taking it tonight have no idea, and that is just one of the 9 medications I am going to cover today. I want to be very clear about something before we go any further. I am not telling you to stop taking any medication. That decision belongs to you and your physician. What I am telling you is that there are conversations happening in research labs and in medical journals that are not happening in your 12-minute appointment, and you deserve to know what those conversations contain. I'm Dr. Marcus Reed. I'm 58 years old. I practice in Boston, and I specialize in brain health, metabolic function, and aging for adults in their 50s, 60s, and beyond. At 58, I think about this for myself. Several of these medications are ones my own patients have been on for years, prescribed by good doctors for real conditions, with no one ever mentioning what the long-term neurological picture looks like. That ends today. Subscribe to Dr. Marcus Reed and hit the like button. What I'm about to share, a 12-minute annual physical, does not have time to cover. That is what this channel is for. Before I name the medications, I need to explain the mechanism. Because once you understand how drugs damage the aging brain, everything else makes sense. Your brain is protected by something called the blood-brain barrier. Think of it like the drywall in your house. When it's intact, nothing unauthorized gets through. When moisture gets in and it starts to crumble, everything that shouldn't be there starts seeping in. As we age, that barrier becomes more permeable. More things get through. This is normal aging physiology, but it means that after 50, your brain is significantly more vulnerable to the chemical effects of medications than it was at 35. The second mechanism is acetylcholine. This is one of the most critical neurotransmitters in the human brain, the chemical messenger responsible for memory formation, attention, and learning. Your brain needs acetylcholine to consolidate new information, to retrieve stored memories, and to maintain focused thought. A large class of medications blocks acetylcholine activity in the brain. These are called anticholinergic drugs. And what research has shown, in study after study after study, is that the cumulative burden of anticholinergic medications over time is directly associated with accelerated cognitive decline and increased dementia risk. Cumulative means the total load across all the medications you are taking. Each one adds to the burden, and the burden compounds. The third mechanism is mitochondrial disruption. Your brain cells are among the most energy-demanding cells in your body. They rely on mitochondria, the power plants inside each cell, to keep functioning. Certain medications interfere with mitochondrial efficiency in neurons. When brain cells can't generate energy properly, they slow down, then they start to fail. Now, the 9 medications. Medication number 1, diphenhydramine. This is the pill I mentioned at the opening. The active ingredient in Benadryl, Ziquil, Unisum, Tylenol PM, and dozens of other over-the-counter sleep aids and allergy medications. Diphenhydramine is a first-generation antihistamine, and it is one of the most potently anticholinergic substances available without a prescription in the United States. A landmark study published in JAMA Internal Medicine followed over 3,000 older adults for 7 years and found that cumulative use of anticholinergic medications, with diphenhydramine as one of the most common, was significantly associated with increased dementia risk. The people with the highest cumulative exposure had a 54% higher risk of dementia than those with the lowest exposure, 54%, for a drug that is marketed as a gentle sleep aid. That sits next to the checkout counter at CVS, that your doctor may have told you is perfectly safe. The reason it helps you sleep is the same reason it damages your brain. It crosses the blood-brain barrier, suppresses the nervous system, and blocks acetylcholine activity. Short-term, you feel drowsy. Long-term, that repeated chemical suppression of the cholinergic system leaves a mark. What to do instead? If you need sleep support, magnesium glycinate at 300 to 400 milligrams before bed works through a completely different mechanism. It does not cross the blood-brain barrier in the same way and has no anticholinergic activity. Low-dose melatonin, half a milligram to 1 milligram, not the 10 milligram doses most Americans take, supports your natural sleep cycle without blocking acetylcholine. Medication number 2. Proton pump inhibitors. Omeprazole, pantoprazole, esomeprazole, lansoprazole. Sold under names like Prilosec, Prevacid, Nexium, and Protonix. These are among the most prescribed medications in the United States. Tens of millions of Americans take them daily, many for years, some for decades, for acid reflux and heartburn. Here is what most of those patients are never told. Proton pump inhibitors significantly impair the absorption of vitamin B12, magnesium, and zinc, nutrients that are absolutely essential for neurological function. They do this by reducing stomach acid, which is required to release these nutrients from food and supplements. Vitamin B12 deficiency is one of the most underrecognized causes of cognitive decline in adults over 55. It damages the myelin sheath, the protective coating around nerve fibers, leading to slowed nerve conduction, memory impairment, and in severe cases, irreversible neurological damage. A study published in JAMA Neurology found that long-term PPI use was associated with a 44% increased risk of dementia. The risk was higher with longer duration of use. The issue is not the medication itself crossing into the brain. The issue is what it quietly strips from your body over months and years, the nutritional foundation your neurons depend on. What to do instead? If you are on a proton pump inhibitor long-term, ask your doctor to check your B12, magnesium, and zinc levels at your next visit. Ask specifically for methylmalonic acid, the functional B12 marker, not just serum B12, which can appear normal while functional deficiency is already causing damage. And ask whether your acid reflux has a mechanical cause, like a hiatal hernia or visceroptosis that could be addressed without long-term acid suppression. Medication number 3, benzodiazepines, Xanax, Valium, Ativan, Klonopin. These are prescribed for anxiety, panic disorder, and insomnia. Millions of Americans over 50 are on them. Many have been for years. A meta-analysis published in the British Medical Journal analyzed data from over 800,000 patients and found that benzodiazepine use was associated with an 84% increased risk of Alzheimer's disease. People who took them for more than 90 days had significantly higher risk than those who took them briefly. The mechanism is multifaceted. Benzodiazepines enhance the effect of GABA, an inhibitory neurotransmitter, which is why they reduce anxiety and induce sleep. But they also suppress hippocampal activity. The hippocampus is the brain structure that forms new memories. Suppress it repeatedly, for months, for years, and the structural consequences are measurable on brain imaging. They also severely suppress deep, slow-wave sleep, the phase where your brain's glymphatic system runs its cleaning cycle, flushing out amyloid plaques and other toxic metabolic waste that accumulates during waking hours. Nights of benzodiazepine-induced sleep are nights the brain's janitor crew doesn't show up. I am not telling you to stop an anxiety medication cold turkey. Benzodiazepine withdrawal can be medically dangerous and must be managed carefully with a physician. What I am telling you is that if you have been on one of these for years, that conversation about tapering strategies is one worth having. Medication number 4, anticholinergic bladder medications. Oxybutynin, tolterodine, solifenacin. These are prescribed for overactive bladder, a very real and disruptive condition, especially in women over 60. The problem is the mechanism. These drugs work by blocking muscarinic receptors, which are cholinergic receptors, throughout the body, including in the brain. They reduce bladder spasms. They also reduce acetylcholine activity in your brain. A study from the University of Nottingham followed over 58,000 patients and found that people prescribed anticholinergic drugs, including bladder medications, had a significantly increased risk of dementia. The risk increased with higher doses and longer duration of use. What many patients don't know is that there is a newer class of bladder medication, the beta-3 agonists, including mirabegron, that works through a completely different mechanism and does not have the same anticholinergic burden on the brain. If you are currently on oxybutynin or tolterodine, that conversation with your urologist is worth having. Ask specifically about the anticholinergic burden and whether a beta-3 agonist is appropriate for your situation. Medication number 5. Certain blood pressure medications. Not all blood pressure medications carry the same neurological risk. Some, particularly the calcium channel blockers like amlodipine, actually appear to have neuroprotective properties in some research. But two classes deserve attention. Beta blockers, particularly the older, non-selective ones like propranolol, cross the blood-brain barrier and can cause cognitive slowing, depression, fatigue, and memory impairment in susceptible individuals. Many patients on beta blockers who complain of brain fog are told their symptoms have nothing to do with their medication. The research suggests otherwise. Certain diuretics, the water pills used for blood pressure and heart failure, deplete magnesium, potassium, and thiamine through increased urinary excretion. Thiamine, or vitamin B1, is critical for neurological function. Chronic thiamine depletion is associated with a specific neurological syndrome called Wernicke's encephalopathy. Subclinical thiamine deficiency, not severe enough to produce obvious symptoms, may contribute to cognitive sluggishness that gets attributed to aging. If you are on a beta blocker and experiencing brain fog, mention it explicitly at your next appointment. Ask about switching to a more brain-neutral antihypertensive, and ask your doctor to check your magnesium and thiamine levels, especially if you're on a diuretic. Medication number 6. Statins. I want to address this one carefully because the evidence is genuinely mixed and I don't want to add to the existing confusion in this space. Statins are prescribed to over 35 million Americans for cholesterol management. For people with established cardiovascular disease, the evidence supporting their benefit is strong, and I am not challenging that. What I am raising is a subset of patients, predominantly women, older adults, people with lower baseline cholesterol, who report significant cognitive side effects on statins: memory impairment, word-finding difficulty, mental fog. The FDA added a label warning about cognitive effects to all statins in 2012. The proposed mechanism involves cholesterol's role in neurological function. Your brain is 60% fat by dry weight. Cholesterol is a critical structural component of every neuron. It is essential for synapse formation and maintenance. Dramatically lowering cholesterol production throughout the body, including in the brain, may have unintended neurological consequences in some individuals. This does not mean statins cause dementia across the board. Some research actually suggests a protective effect in certain populations. The picture is complex. What I am saying is this: if you started a statin and noticed cognitive changes, and then attributed those changes to aging, that connection is worth revisiting with your physician. A trial pause under medical supervision, if cardiovascular risk permits, may clarify whether the medication is contributing. Medication number 7. Sleeping pills. The Z drugs. Zolpidem, Esopiclone, Zaleplon. Sold as Ambien, Lunesta, and Sonata. These are prescription sleep medications taken by millions of Americans, many of them nightly for years. A large study published in the British Medical Journal found that use of hypnotic medications, including the Z drugs, was associated with a 4.5-fold increased risk of death and significantly increased cancer incidence. But beyond mortality, the neurological picture is concerning. Like benzodiazepines, Z drugs suppress slow-wave sleep, the deepest, most restorative phase where glymphatic clearance occurs. People on these medications spend less time in slow-wave sleep than people who sleep naturally, even when total sleep time is similar. The brain appears to sleep. But the cleaning crew still doesn't come. Long-term use is also associated with rebound insomnia. When you try to stop, sleep becomes worse than before you started, creating a dependency cycle that is very difficult to exit without a structured tapering plan. What to do instead? Cognitive behavioral therapy for insomnia, CBTI, has been shown in randomized controlled trials to outperform sleep medication for long-term insomnia, with no side effects and no cognitive burden. Ask your physician for a referral. It is the gold standard non-pharmacological treatment. Medication number 8. Certain antidepressants, specifically the tricyclic antidepressants, amitriptyline, nortriptyline, doxepin, and some of the older antihistamine-type antidepressants. These have significant anticholinergic activity and have been included in the same research that implicates diphenhydramine and bladder medications in dementia risk. The newer SSRIs and SNRIs, fluoxetine, sertraline, venlafaxine, have a much lower anticholinergic burden and are generally considered safer from a cognitive standpoint. The issue I see clinically is that many older patients were started on a tricyclic antidepressant years ago, often for pain, sleep, or depression, and have remained on it without anyone reassessing whether it is still the best option. If you are on amitriptyline or a similar older antidepressant, the conversation with your prescriber about whether a cognitive burden assessment is warranted is a reasonable one to initiate. Medication number 9. Acid reducers, the H2 blockers. Famotidine, ranitidine, cimetidine, sold as Pepcid and formerly Zantac. These are less potent acid reducers than proton pump inhibitors but are still widely used. Cimetidine in particular has documented anticholinergic activity. Famotidine is generally considered lower risk, but long-term use still impairs B12 absorption through the same mechanism as PP is, reduced stomach acid. A study published in the European Journal of Internal Medicine found associations between H2 blocker use and cognitive impairment, particularly in older adults with prolonged use. The practical point: if you are taking an H2 blocker regularly for months or years, the same nutritional monitoring I described for PP applies B12, magnesium, zinc, and the same conversation about whether the underlying cause can be addressed rather than suppressed indefinitely. Now, let me give you something actionable. Because knowing the risk without a path forward is not useful, here are the 3 questions to bring to your next medical appointment. Question 1. What is the total anticholinergic burden of all my current medications combined? This is a formal clinical concept. There are published scoring tools, the Anticholinergic Cognitive Burden Scale, that assign a score to each medication. A physician can calculate your total burden and identify whether it crosses the threshold associated with cognitive risk. Question 2. Are any of my current medications depleting nutrients that my brain depends on? Ask specifically about B12, magnesium, zinc, thiamine, and Co. Q10 if you are on a statin. These are standard blood tests. They can be added to your next routine draw. Question 3. For any medication I have been on for more than 2 years, what is the current evidence on long-term neurological effects? And is there a safer alternative with equivalent efficacy? You are not challenging your doctor's judgment by asking these questions. You are being an informed participant in your own care. A physician who sees a prepared, specific patient works very differently than one who sees a passive one, and write down the names of every medication you take, including over-the-counter drugs like diphenhydramine, before that appointment. The full picture only exists when everything is on the table. How old are you right now? Drop it in the comments below. After 50, the blood-brain barrier becomes progressively more permeable, the cholinergic system becomes more vulnerable, and the cumulative medication burden accumulates faster relative to your neurological reserve. Your age changes how urgently I would frame this conversation with your physician. Tell me in the comments. Here is your action plan before your next appointment. Step 1. Make a complete list of every medication and supplement you take. Prescription, over-the-counter, and anything purchased at a pharmacy. Include sleep aids, allergy medications, and anything you take occasionally. Step 2. Search each one for anticholinergic activity. Look up the Anticholinergic Cognitive Burden Scale online. It's publicly available. See where your medications fall. Step 3. If you take a proton pump inhibitor, H2 blocker, diuretic, or statin, ask for B12 methylmalonic acid, magnesium, zinc, and thiamine at your next blood draw. Step 4. If you take diphenhydramine for sleep, try magnesium glycinate at 300 mg tonight instead. Give it 2 weeks before drawing conclusions. Step 5. If you take a benzodiazepine or Z drug nightly, ask your physician about a structured taper and a referral for CBTI. Do not attempt to stop these medications suddenly on your own. Everything I've covered today is for your education and understanding. Your situation is unique. Some of these medications may be absolutely the right choice for you. The benefits may clearly outweigh the risks in your specific case. Use this as a starting point for a real conversation with your physician, not as a reason to stop anything unilaterally. If your last appointment ended with "here is your prescription and see you in 6 months," and nobody has ever looked at your complete medication list through a neurological lens, that conversation has not happened yet. It should. Subscribe to Dr. Marcus Reed, hit the bell, and if you know someone over 50 who takes a sleep aid every night, or has been on an acid reducer for years, or is on anxiety medication they were never told might affect their memory, send them this video. That conversation might be the most important one they have this year. I'll see you next time. Take care of yourselves. I mean that.